Good afternoon, everybody. I'm Marcus Tai, Dean of the College of Health Professions. Thank you all for joining us today. Today's special alumni guest is Dr. Donald E. Moore. I had the privilege of hearing Dr. Moore when I was attending a Zoom when Dean Grimes had invited him to speak, and you really are in for an intellectually stimulating, informative, and very important talk today. Dr. Moore has practiced primary care medicine in Brooklyn for more than 35 years. He has distinguished himself through service to his community and his profession. He is an attending physician at the New York Presbyterian Brooklyn Methodist Hospital and teaches medical students at Weill Cornell Medical College and Downstate Medical School. He also teaches nurse practitioner students at NYU and Hunter College. Dr. Moore has received many teaching awards. He has been recognized for his humanitarian efforts in healthcare delivery by the New York State Legislature and the United States Congress. Dr. Moore began his education right here at Pace University in 1976 with a Bachelor of Science in Biology. He earned a Doctor of Medicine and a Master of Public Health at Yale in 1981. We are thrilled to have been part of his successful journey. It is my deep pleasure and honor to welcome Dr. Moore as he presents Racism and the Social Determinants of Health.
Well, good evening, and thank you all for coming. Thank you for standing room only. It makes me feel like a celebrity. Well, of course, this is serious business, so I know your university wouldn't bring you here just for entertainment. You can do that later. So we're going to get right into it. Social determinants of health and racism. So let's start off with the definition of health. The World Health Organization, that's sort of like the big worldwide agency that tells us all, you know, how to run our public health and how we're doing, those people. Health, they define health as a state of complete physical, mental, and social well-being, and not merely just the absence of disease. So we're not just talking about illness. That's how most people tend to think of health. So the World Health Organization says we've got to go further. In addition, they say that health is fundamental well, first of all, health is a right. That's what they say. It's a natural right. And of course, peace and security, it's necessary to have good health for peace and security. That's what the World Health Organization has told us. And they continue that the promotion and protection of health is of value to all. So it's not just the government or the individual, it's all of us. It's necessary that everybody around you is healthy. And you'll see that develop as we go through the talk. And finally, it says if there is unequal development of health, whether from country to country or from individual to individual, that will present a common danger to everybody else. As a matter of fact, we see that in the world today. So now we understand health, not just the absence of disease, but complete mental, physical, and social well-being. Now we see what that is. Well, what are the determinants of health? What makes us healthy? Well, this particular study, this is not exactly a study, this was concept that was put together initially by McGuinness, but was outlined in the Shattuck lecture, which is a main lecture that's given once a year and published in the New England Journal of Medicine. That's sort of the peer-reviewed doctor's journal. That's sort of the Bible of medicine. Well, this lecture, given once a year on issues like this, Shattuck, Schroeder, in his Shattuck lecture, looks at health from this perspective. First of all, he says that it's not okay just to well, let's go to here first. Identified as the various contributors to health is behavioral aspect. Now, the behavioral aspect is the largest contributor to one's health, right? Now, what are the behavioral factors? Those are things like whether you smoke cigarettes, you drink alcohol, you don't eat well, you don't sleep, you hang out all night and party, stuff like that. That will contribute to your health or ill health, and that's about 40%. The other 30% is, the genes you got. If you're born with sickle cell disease, your life expectancy is going to be limited. Your health, most of the time, how you feel, that feeling, we talked about the state of mental, it's not going to be always great. And so you can't change your genes. If two of your parents have sickle cell disease, well, if one of your parents has sickle cell disease, you have a high chance of getting it. And if both of them have the trait, you have a 1 in 4 chance of having that disease. So you don't control that. Your environment may help a little bit. And that's the other aspect. The other third that's left, those are the social determinants of health. We're going to talk more precisely what those are. But if you look at this pie chart, you'll see that your social circumstances, which is your socioeconomic status, that's going to be a main contributor to your health. Your environmental exposure, if you're exposed to lead from the paint on your walls, that's going to clearly affect your health. And if you have no access to health care, that's going to affect your health. Now, if you notice what it says that health care, the care you get from your doctor, your nurse, and your health provider, that's only 10% of what determines your health. So let's now look at the WHO definition of the social determinants of health. We talked first about health. Now, what about the social determinants? So the World Health Organization defines the social determinants of health as the conditions in which people are born, they grow, they work, they live, and they, die. It says age there, but they're really talking about that process of dying, which is the most expensive part of our healthcare delivery, as most of you already know. So I'm not going to go through all the points on this slide, but if you sort of glance at it or just sort of scan it, you'll see that there are many contributions to the social determinants of health. It could be anywhere from your income to, your sexual orientation. How do we measure health? Well, we can measure it from the individual, or we can measure it as a population. Now, you'll hear me talk about the herd. Unfortunately, or fortunately, we're part of a herd. We're not individuals. We're not here by ourselves. Whatever we do impacts each other. And I can tell you, if you take one individual and just take them out away from everybody else, they're going to have poor health. So we function as a herd. And you've heard things like herd immunity and so on. And that's the reality of what happens. So if we look at health from an international perspective, then there's certain measures that we can use to measure how we're doing. So for example, infant mortality. Many of you already know the definition, but let me remind a few of you who don't know that infant mortality is the deaths of children less than 1 year old. So if a woman delivers and her baby dies before they get to 1 year old, that's a very important measure. That's the infant mortality. As a matter of fact, we identify a high infant mortality rate with state failure. It's a good predictor that this state is not doing well. By state, I mean government. So if you look at the graph here, the bar charts here. That's not it either. I was trying to get my pointer, but hold on. Anyway, if you look, you'll see the red is the United States. Now, the comparator countries are countries with similar socioeconomic level as the United States, pretty much high-income countries. So if you rank 227 countries, and this, you're going to see this, I'm going to bring this up again, so I'm kind of going to orient you as to how this is, how I'm actually doing this. This is a data set. So the numbers here are not necessarily exactly the way they are today, and everybody has different data sets. But if we use the data points from the data set, we can compare countries. And in this particular situation, we see that Japan has a much lower infant mortality rate than the United States. And of course, countries like China and Russia, they tend to have a higher infant mortality rate. But if you look at the comparator countries, countries like the UK, Australia, Germany, France, they're all doing better. So from a comparison, an international comparison, the United States has a relatively high infant mortality rate and ranks worse off than most of the similar countries as far as economics. Another measure of one's health, the health of a population, is the maternal mortality ratio. Also, we use the term maternal mortality rate. Again, you'll see countries like Australia, Germany, Japan have a much lower maternal mortality rate. Now, again, the definition here is the maternal mortality ratio is the number of maternal deaths during a given period per 100,000 live births during that same period of time. So 100,000 live births occur. How many women died giving birth? That particular measure corresponds to the quality of a healthcare delivery system. So you're getting the picture where I'm going with this. If we're looking at all these indices, maternal mortality, infant mortality, and we see that the United States is not doing so well. Well, if the children die before they get to 1 year old, or the mothers die giving birth, eventually that's going to impact our life expectancy. The life expectancy is sort of a compilation of our overall health. Life expectancy in the United States, again, if you compare it to similar countries, life expectancy is actually less. As a matter of fact, significantly less. Americans live 5 years less than Japanese, and 3-4 years less than everybody else in developed countries. So you've looked at the data as put together in these data sets. Well, what does our Institute of Medicine, it's now the National Academy of Medicine, what that is, that's an organization that, that's our think tank on health, right? National Academy of Medicine. Well, back in 2013, they actually put together a group of experts and say, well, let's look at this from an international perspective. Same data they looked at that you just looked at before, and they came to the conclusion that Americans have shorter lives and poorer health. Shorter lives and poorer health. And if we, and they define it, they compared 17 countries, and of the 17 countries, the United States has the highest or near highest prevalence of infant mortality. You know about that. Prevalence of heart disease, lung disease, sexually transmitted infections. You know, some of those STIs actually you die from. HIV is one example. Adolescent pregnancies. that's a problem, right? We're talking about infant mortality, maternal mortality, injuries, homicides, and disability. So all those things contribute to what we define as poor health, what the WHO defines as poor health, which is not just the absence of disease, but not a state of complete physical, mental, and social well-being. So the main focus of this talk is not about health in general, and not about, it's really about the disparities. Because if you remember from the earlier slide, the World Health Organization basically says when there is unequal development in health, it affects all of us. So Healthy People 2030 is sort of the US government's goals. So we now have Healthy People. When I started out, it was Healthy People 2000. You know, we were looking ahead. Now we're Healthy People to 2020, and now we're up to Healthy People 2030. So these are the goals. And of course, the CDC, Center for Disease Control and Prevention, their definition of health disparities is preventable differences in the burden of disease. Preventable differences. So again, the health we're talking about, or the control of health that we're talking about the preventable portion. Remember, those are the social determinants or the behavioral portion. The National Institute of Health, again, our government agency that guides us health-wise, they refer to health disparities. In the United States, disparities is often interpreted as racial or ethnic disparities involving structural racism, I'll talk about that in a little bit, and other forms of unfair and unjust discrimination that creates gaps in health, either between populations or within populations. So we're looking at it from two perspectives. We're looking at it from what happens in the United States within the population, and how the United States compare to everybody else internationally. So the World Health Organization, they define health inequities as unfair and avoidable, again, preventable, differences in health between groups of people within individuals within the country and between countries. And they point out that the inequities that we see stem from the social determinants. Socioeconomic status, just so we're on the same page, socioeconomic status refers to the social and economic factors that influence the position individuals hold within a society. This includes factors such as occupation, class, education, income, and wealth. They go on to say that individuals with higher socioeconomic status consistently experience better health outcomes than those with lower socioeconomic status. You think, really? Yeah, anybody disagree with that? So what if we ignore this whole thing? Well, the premise is that we're going to harm patients. We're going to harm people if we ignore it. And examples are right there in front of you. Flint, Michigan. That was just 4 people getting a bad deal. We're going to, in a few minutes, I'll show you where racism can affect health, regardless of one's socioeconomic status. Things like mass incarceration, police violence, you know, those are the things we hear in the news all the time. Stop and frisk, bad for your health. Eric Garner, he died. That was an outcome right then and there because he came into interaction with the police. George Floyd, a similar situation. We see it in the delivery of medical care with respect to screenings. We saw it with the recent pandemic. And of course, just our day-to-day lives. People with lower socioeconomic status really have less access, and they tend to have poorer outcomes. So let's start off with one aspect of those social determinants. And this, this is let's talk about the structural determinants. Okay. So the housing discrimination. In 1933, after the Depression, the United States government, in order to, I guess, help everybody, they developed an agency known as the Homeowners Loan Corporation. And this particular agency was to help provide loans to individuals who needed to buy houses. Well, the government gave the banks guidelines to say who you could give these government loans to. And they literally went around to over almost, I think that was almost 239 different districts, cities, whatever. Not cities, but districts, and drew red lines around them and say, these people are likely to be high risk. And the only reason that they were high risk in terms of repaying their loans, as determined by the government, was their race, because they were Black. And you've heard the term redlining. This redlining has been associated with poor health outcomes. And again, you'll see. Redlining results in Blacks being exposed to higher level of environmental toxin, because if you live close to industrial pollutants, that's going to have an adverse effect on your health. It's going to have an impact on which schools you go to, what hospitals you have access to, and so on. So I'm going to give you and show you an example of how racism can affect one's health.
This is Democracy Now!, democracynow.org, The Quarantine Report. I'm Amy Goodman. As the United States reports world record deaths and hospitalizations from COVID-19 in the final days of 2020, we look at how the pandemic that's ravaged the country this year has shown stark new light on racism in medical care. We begin with a now viral video recorded by Black physician Dr. Susan Moore and posted to her Facebook earlier this month, in which she describes racist treatment by medical staff at a hospital in Indianapolis who did not respond to her pleas for care despite being in intense pain and being a doctor herself. Dr. Moore says she had to beg to receive the antiviral drug remdesivir and pain medication, and accuses a doctor at Indiana University Health North Hospital of ignoring her pleas because she was Black. This is Dr. Susan Moore as she summoned the energy to speak from her hospital bed days before she would die. She had an oxygen tube in her nose.
At that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting. So I spoke to patient advocate who left me wanting. There's not much I can do. So I started asking, send me to another hospital where they can treat me. And if they're not going to treat me here properly, send me to another hospital. Well, next thing I know, I'm getting a stat CT of my neck with and without contrast. The CT went down a little bit into my lungs, and you could see new pulmonary infiltrates, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward and I maintain, if I was white, I wouldn't have to go through that. The other thing that white Dr. Bannock said was that if I stayed, that he would send me home Saturday at 10 p.m. in the dark. Who does that? On a weekend, who does that? This is how black people get killed. When you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody, to let people know how I'm being treated up in this place. And he gladly told me, I know you're a doctor. So he didn't want the black doctor to have no medicine, nothing. And then had the nerve to say it's because of him, the nurse, that I got the medicine. Really? Because of you? No. How about because I had that stat CT in my neck where it showed all of that lymphadenopathy and infiltrates? Yeah, you didn't know about that? You didn't get that in report? That's what I said. To being black up in here, this is what happens.
Dr. Susan Moore died due to complications from COVID-19 on December 20th, just over 2 weeks after she recorded this video and posted it to her Facebook page. She was 52 years old. Her 19-year-old son, Henry Muhammad, is now left to care for her parents, who are both suffering from dementia. The president and CEO of Indiana University Health issued a statement in response to her death, saying the technical aspects of the treatment she received, quote, may not have shown the level of compassion and respect we strive for in understanding what matters most to patients, unquote.
Well, certainly Dr. Moore, not my relative, but she had access. She was, I would not define her as low socioeconomic status. She was in the right place to be treated. It's hard to figure out why such a young person, and remember, the young people weren't dying of COVID. It was, you know, we don't know all her risk factors, but here's an example of, despite everything else, we can't figure out, or maybe we can figure out, this is an instance where racism was the determinant factor. Well, 10 years before this, the National Academy of Medicine, Institute of Medicine, actually looked at this problem, confronting racial and ethnic disparities in healthcare. Racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, regardless of your access, regardless of your health insurance, and so on. They go on to say that the sources of these disparities are complex and are rooted in historic and contemporary inequities. So I'm going to just change gears right now and explore some of those racial and ethnic issues. scientific racism. We don't talk about that today, even though we should, because it has a specific historical beginning. So imagine just before the Civil War in the United States, right? 1860 to 1865. Building up to that Civil War, for some reason, America needed to explain racial disparities. So the whole field of scientific racism developed. That is a belief that empiric evidence exists to support or justify racism. So if you look at this section of this collage, you'll see the gentleman, physician and natural scientist, Samuel George Morton. Now, how did this guy, this doctor, get to the books? Well, he wrote Crania Americana in 1839. He actually had collaborated with Glidden, who was actually an Egyptologist. And what Glidden did was he actually brought mummies from Egypt, and Morton studied them. Morton went further. He started collecting skulls. And he developed the idea, the philosophy, the theory, the premise that skull size, cranial capacity, the size of the inside of your skull, correlated with your intelligence. And so he had over 1,000 skulls, and he painstakingly measured the skulls, supposedly, and came to that conclusion. He was also a polygynist. And what that is basically somebody who believes that individuals, all human beings, different human beings came from different origins. Now, of course, most of the religious texts, the Bible, et cetera, tell you that human beings came from one origin, whether it's Adam and Eve or whatever it is, but they came from one. Well, there were people in this time that felt, well, you know, we've got to explain why we're treating these people differently. We've got to explain why we need to still have slaves, even though the Atlantic slave trade was outlawed in 1807, right? But slaves were still in the United States between 1807 and 1865. So how do you explain it? Well, these are different people. These are not the same as us. So eventually, Glidden, along with Josiah Nott, that's the gentleman at the top with the white beard, they actually, after Morton died, somewhere in the 1850s, later on in that decade, Nott and Glidden actually used the work of Morton to promote this idea. They wrote a couple of major works, Types of Mankind, and if you look at those, drawings, it shows you that they are various types, but the main types were the Caucasian at the top, and of course, a group that looks similar to apes or certainly not human beings. So this series of ideas developed even further. Let me tell you a story about the one in the middle. His name is Louis Agassiz. He was born in Europe, Swiss, he was Swiss. He came to the United States, went to Harvard as again, natural scientist, biologist. And his feeling was, well, you know, these Black people, I've never seen them before, but I've heard about them. So let me go to where Martin was, which was in Philadelphia, and look at these people. So he went, he collaborated with Martin, and what was most interesting was he actually developed slave portraits with a photographer named Seeley. Now, photography was very early in that time. As a matter of fact, the type of photography used then were daguerreotypes, and this is what they look like. Now, if you kind of zoom in on this, something is not right. All the men, and back then, most of the people who were going to be in photographs were going to be men like this, especially if you're talking about scientific subjects, but they're all dressed like human beings, dressed at that time. But that's how Agassiz displayed the Black people of the time. And this other gentleman here, this was actually a working physician, Cartwright. He elaborated on this work and even created medical diseases and terms, such as dysesthesia ethiopica. It basically was just he thought that the slaves had this particular disease, habitude that made them lackadaisical and whatever. As a matter of fact, the most interesting of the diseases and terms that he coined was drapetomania. And drapetomania basically is the idea that these people who were slaves, they always wanted to run away. Something must be wrong with them because they always want to run away, drapetomania. As a matter of fact, in 1840, the United States did a census. And in this census, this was like the sixth census of the United States, the sixth, census started back in the 1790. In this particular census, they dug deeper, not just counting people, but they were looking at diseases within the census. And they came to the conclusion that free Africans or free African Americans, free Blacks in the North had more lunacy, which is mental disease, than the actual slaves in the South. So all of these were reasons to explain why slavery was good. And that's scientific racism. That's the whole concept of scientific racism. Goes even further. If you look at that photograph of those men, circled at the top is actually a Black man. Now, that is the graduating class of Medical College of Georgia, Medical College, so those are physicians. Some of them in the front are actually professors. Well, how did he get there? Well, back in around 1850, during the same period of time that we're talking about, the professors went and bought a slave. His name was Grandison Harris. He was probably, we're not sure, in his 20s or his 30s, and they bought him because he was big and strong. And supposedly his job was a porter. As it turns out, that was not his real job. His real job was to go to the cemeteries and dig up the bodies, bring it to the medical school so they could do their dissections, etc. Now, of course, why was that necessary? Back then, you couldn't do dissection on people in Georgia and in the United States and many parts of the world. So what most schools, many schools did at that time, they would get illegal bodies to dissect because that was the material that was needed to train doctors. Well, Grandison Harris did this until the emancipation occurred in 1865. Now, he was very special because he was taught to read and write. And the reason they taught him to read and write was so that he could read the obituaries to figure out where the graves were going to be, where the people who were recently buried were going to be. And he needed to read if there were stones, which most of the time there weren't. But he would follow all of this. And then eventually the night they were buried, go dig up the body and put everything back together. And nobody was the wiser. The people in the community knew it. The doctors in the hospital knew it, but they didn't. So this went on until actually the 20th century, about 1905 or so. Even by then, it was legal to get bodies, but they needed those extra bodies. And this continued till his son took over. And when he died, they did bury him in the same cemetery, but he didn't have to worry because his son was the one who took over. So we see this relationship between the society and not just the live people, the live slaves, but even after you died, there was a problem. I show you here this, I'm not sure what that is. Maybe it's I don't think, it's not a photograph, it's probably a drawing, because she died in 1815 when we didn't have photography back then. So it may be a photograph of a drawing, but her name was Sartje Bartman. That's, Sartje was her, I guess, European name, but she was an object to be displayed, and that's exactly what happened. She was brought from Southern Africa to the United States and to Europe, where they actually put her on display, and many women like her were displayed under the term of the Hottentot Venus. If you think that's strange, this is even more strange. In 1906, Southern African man was brought for display, actually put in a cage in the Bronx Zoo with animals. So we're talking about 20th century here, 20th century. So I'll stop for a moment and remind you what we're talking about. We're talking about how a health professional may view the person they're treating and not realize that there is a whole historical set of circumstances that may make them feel different about that particular individual. Other examples of exploitation, and we're talking about Black exploitation, is Henrietta Lacks. Many of you know about her. This is a woman who was in Baltimore, living in Baltimore, developed cervical cancer, was biopsied. They took her cells. The pathologists that got the cells for review actually noticed that these cells had a particular ability to grow, where it was able to culture cells. Back in those days, we weren't able to culture cells. Her cells were culturable, and those cells were eventually distributed all over the world and was involved with the development of vaccines, et cetera, et cetera, et cetera. Many papers were written about that. The point here is not that her cells were used, is we use a variety of tissues and organs or whatever. It's the fact that she didn't benefit at all. She died, her family did not benefit, and for years this was just kept under wraps until it was eventually made very public by Rebecca Skloot, who wrote that particular book about her, and there is even a TV movie, I understand, about her. So let me spend a couple of minutes just talking about the syphilis study, the Tuskegee syphilis study. Now, in 1932, the United States government started a study on African-American men in Tuskegee. Now, they didn't say that's what they were doing. If you look at this, I don't know if you can see this here, but it says colored people, free blood tests, free treatment. That's what was advertised. But what was done and what was planned was that these men were going to be followed without treatment. For 40 years, they were followed, and subsequently, the study was stopped. During the interim, that period, blood and spinal fluid was drawn. Those specimens were used to develop testing for syphilis. And again, no permissions. These men weren't asked permission to be in a study. They were told that they were going to be getting treatment. The woman in the picture, Eunice Rivers, this was a public health nurse, and she was actually hired to be part of the research team. Unwittingly, her job was to make sure the men showed up for their blood drawing, and later, as they aged, to make sure that we knew where they were when they were about to die, so they could die in hospitals controlled by the group, by the study individuals, so that they could actually do an autopsy. So again, even after life, there was exploitation and discrimination. And I could go on and on. I have others here, Acres of Skin. This Dr. Klingman, what he did was he experimented on prisoners. Acres of Skin was the book that identified that. And Retin-A, which many of you use on the face, was this doctor that developed it by experimenting on people who are incarcerated. And of course, many of the things I've spoken about is from the book Medical Apartheid, Washington, Harriet Washington. And of course, there are stories of people being injected with radioactive material, et cetera, et cetera, et cetera. Of all forms of inequality, injustice in health is the most shocking and most inhuman. Martin Luther King. Injustice in health. This is what existed in the society, Jim Crow, et cetera, et cetera. This is what occurred on the professional level. So throughout the 20th century, the first half of the 20th century, even though Black physicians were trained, African-American physicians were trained, they couldn't practice in the hospital. The reason they couldn't practice in the hospital is because they couldn't join the medical society. And locally, the medical societies would not allow them. And in order to get to the hospital, you needed to go through the medical society. So that didn't change until the 1960s with the civil rights movement. Medical apartheid is part of what I was just discussing, the fact that there was a difference in the way in which African Americans, in particular, were treated compared to whites in America. Segregation, separate and unequal facilities, private versus public hospitals. But wait a minute. I said in the 20th century, we're in the 21st century and we're still doing this, right? Private versus public hospitals. Jim Crow hospitals, they existed in the first half of the 20th century. Jim Crow hospitals was basically where Black patients were put in a different part of the hospital than whites. They entered through separate entry. They went to the hospital through separate entries. Health insurance, HMO versus PPO. HMO, if you have a low-paying job, you're going to get an HMO. If you're the higher rank, you're going to get a PPO. Even when you age to Medicare, Nowadays, we have two types of Medicare. We have regular Medicare for people who can afford the part of Medicare that you have to pay out of your pocket versus Medicare Advantage. So those separations still exist. So the point is, well, why should you care about scientific racism and medical apartheid? Well, you should care for this reason. Martin Luther King said, injustice everywhere is a threat to justice. I'm sorry, injustice anywhere is a threat to justice everywhere. So if you allow injustice here, it's just going to spread all over. And again, I bring you back to the study, the Institute of Medicine study in 2013, that showed the United States, we all, if you take us as a group, we have shorter lives and poorer health. And because of all of those things that I mentioned before. So why don't we just spend more money and that will fix the whole thing? Well, we already did that, been there, done that. We spend twice as much as those rich countries that I showed you were doing better. We spend twice as much as they do. And we're still getting those poor. So what is the goal? The goal is health equity. Health equity means that everyone has fair and just opportunity to be healthy as possible. That state of complete physical and mental. Yeah, so we want everyone to have the same ability to get there. That's health justice. So to be a health professional, it probably suits you to know about health justice because you don't want to be called out by one of your patients on social media to say this doctor, you don't want to be there. So it requires removing the obstacles to health, such as poverty, discrimination, and their consequences. And what are their consequences? If you're poor and you've been discriminated against, you're going to be powerless. You're going to lack access to good jobs with fair pay. You're going to not have access to a quality education. And of course, you're not going to have access to appropriate housing. So, it's my final slide. I want to point out that advancing health, the way to advance health is to focus on the two largest contributors to health: behavioral change and paying attention to the social determinants. So Bradley, who actually public health expert, she points out that residents of nations that have higher ratios of spending on social services and spending on healthcare services have a better health outcome. So the idea here is don't spend all your money, don't give all your money to the doctors and the nurses and the hospitals. Spend some money on housing, spend some money on education, spend some money on improving the population, because 30% of your health is going to be determined by the social determinants. Again, Institute of Medicine pointed out that payment systems should avoid fragmentation along socioeconomic lines. So again, we point out that if you are, if your insurance is Medicare Advantage versus Medicare, you're not likely to get as good an outcome. If you are going to get your health care with Medicaid, you're not going to have access to the best hospitals. Medicaid is insurance for people of low socioeconomic means. It's not good insurance. So my recommendation, let's stop fighting for more Medicare. Let's just fight for one insurance for everybody. Don't let insurance be the dividing line between us. But as an individual, what can you do? You can beware of your own bias. I showed you Nurse Eunice Rivers. She unwittingly participated in that study. And we do this so often. When I say we do this so often, we don't just solve the problem by saying, oh, let's do it in the Black hospital over here. It was done at Tuskegee. That was the Black university. The individuals were from the Black, the autopsies and stuff was done in the Black hospital in Tuskegee. So it's more, this bias, it's not limited to your race. This bias is perversive. We all have it. So the idea is to be aware of it. And of course, once you're aware of it, then don't just sit there and say, well, I won't be prejudiced anymore. I will fight to improve the situation, basically fight to be an anti-racist. And if you want instructions, Ibram Kendi will give you instructions on how to do that. Thank you very much for your attention. And at this point, I'd be happy to take any questions.
We have a mic. If I'll be happy to bring it to anyone who would like to ask a question.
Thank you, Dr. Moore, for a great talk. I was just wondering what you think the role is of, well, so as an educational institution, the role of education in helping people who are underrepresented in medicine getting into medical careers. Do you think that that's going to have a major influence basically over on these issues, where if there are more people that are underrepresented in the medical field, is that going to make a big difference? Oh, absolutely. Absolutely. Dr. Susan Moore would not have the same problem if I were her doctor. I think that's it. There had to be something more why that doctor was so resistant to doing what she asked. Hey, I can't breathe. Well, that's obvious. You got COVID. Yeah. What do you mean you can't breathe? Hey, it hurts. Yeah. Dysesthesia, Ethiopica, the insensate body. So, no, it makes a difference. It doesn't solve the problem, but it does, it's the first step. Do you have another question? All the way in the back.
Hi, I'm just wondering what your thoughts are on our curriculum here in terms of how we're prepared for the workforce and being an agent of change. If you have your own opinions on the level of commitment that you see in our curriculum, if any, but.
Unfortunately, I don't know the details of the curriculum here, but I could tell you that given the outcomes that we have, none of us, no medical school, no institution in the United States has fully prepared the health professionals to deliver the care that is necessary to move us in the direction of Japan, as far or Australia, and so on. So the idea is, clearly, you're sitting in a space right now that's beginning to address the issue. So this is just the start. Hopefully, what I've just shown you, and obviously I could not have gone through the entire thing in 45 minutes or so. This is a whole course. This is gonna, if you want to look at something like the Tuskegee study, you could spend three different sessions just on that, because there's so many implications to that particular thing. There was this study design. There was the fact that, why are you designing such a study? How can you, when treatment is available for a disease, design a study where you're not going to treat? That's unethical. Then once you start the study, more medicines come and you keep avoiding the treatment. Those men from the Tuskegee study, they started in 1932. By 1950, penicillin was widely available. Do you know what they did when the men were drafted? They sent their names to the armed forces to say these men should not be treated for syphilis if indeed you find out they have it. And even when, you know how many whistleblowers blew the whistle? In the 1950s, a physician, having heard the story presented at the AMA, American Medical Association, wrote a letter to the researchers and said, how could you be doing this? It was ignored. Even when the final whistleblower started blowing the whistle, it took him 10 years and him becoming a lawyer and reporting it to the newspaper before they stopped the study. So clearly, educational institutions don't do enough, governments don't do enough, and we just don't do enough.
I guess I would just add to that is, well, what are the current practicing medical physicians doing in this regard? You know, we're not doing enough, universities aren't doing enough, the government isn't doing enough. So I'm wondering from the current practicing medical profession, what do they want to do and what's happening, if you know, to address this?
I assume I don't know. I don't know what else as individuals we could do other than sort of beat that drum. As individuals, voters, I think we could change our payment system. I think that's something very tangible. Why do we have all these different insurances? The reason we have all these different types of insurances is so we can ration care to different individuals. When Medicare was established, the government had the opportunity to say, okay, let's do the way they did it in Britain. They did it in Britain like, that was 30 years before. They said, okay, but Britain was different to some extent. It was a more monolithic type of society. In America, when we got to that point, we said, well, we can't give health insurance to everybody. We got to figure a way to treat these people separately. I'll give you an example of comments a legislator made to me. So I said, well, in New York State, we have a bill that says, let's have the New York Health Bill. And basically what it is universal single payer insurance for New York State. And the Assemblyman Gottfried had put this together. He had put that bill to the New York State Assembly almost 30 years ago at the beginning of his career. He's now retired. Well, I asked him, I said, well, why can't you get this bill passed? And his answer was just straightforward. He says, well, many New Yorkers, not most, the majority of the people do want what he has offered, but many New Yorkers don't want others to have the same insurance as they have. They want to make sure that with my good insurance that I get from my good job, I will have access to my doctor. And that waiting room will not be filled with those other people. You know, Malcolm Gladwell talks about education. And he said, well, when I applied to college, it took me one evening about a half an hour and it was done. I just decided which school I want to go to. I put my first choice and second choice. He says when he got to America, he saw something different. You know, we make it such that not everybody have access to the same education. Now, me, for example, I went to Yale Medical School, but it wasn't because I had played by all the rules and met all the criteria and ended up there. I happened to get there at a particular time because of what was happening politically in the United States. It was felt that there needed to be greater access to medical school by minorities. The question was brought up before, can we train? And so I was at pace. I think I was doing well. And I was planning to go to medical school and all of that. But there was a thing called affirmative action. Affirmative action says, yeah, PACE is not on our radar, but we have exhausted all the feeder schools to Harvard, to Yale, and all the feeder schools that we have, we only, all those students who've been prepared are no longer gone. We need more. So there gotta be bright students elsewhere. So they started looking around and they just happened to look at PACE and they said, maybe we let this guy in, he's been doing some good work. And it didn't make a difference in the end. Once I was there, I was able to perform equivalent to everybody else. But the difference was when I was done, I became a different doctor than Dr. Bannock, who she called out on social media, who, I went back, I practiced in Brooklyn, and what I was able to deliver in Brooklyn was different. It wasn't necessary, and it definitely, from my point of view, was not a lower level of care. It was as good as any other care, but it was care directed to the people that were there. So the changes need to occur over time. It can't be, we're not just going to flip the switch on. But the fact that I then could become a physician at Yale, accomplish certain things, and then come back and say, well, okay, there are students here at PACE who can get there the same way that I did. But you know what? It's harder now. And the reason why it's harder is because we don't have affirmative action. And of course, are we going to get affirmative action? The Supreme Court just hammered the nail in against affirmative action. So that's the kind of thing we can do. We can change things politically. In addition, of course, to change ourselves and do the preaching. But what's really going to make the difference is governmental policies. Government policies. More medical schools mean more doctors mean more money spent on healthcare. Remember, we want to spend the money on the social determinants of health. Who said more medical schools? You did. Okay, no, I don't agree necessarily. My friend and colleague, Dr. Uche Blackstock, talks about the lack of Black physicians because in 1910, with the Flexner report, they shut down 5 medical schools, 5 Black medical schools. But they also shut down over 40 white medical schools or majority medical schools. More doctors, and despite all of that, we go and we import doctors from elsewhere. That's a different discussion. But more medical schools don't solve the problem. It's this expenditure on health. A different discussion. But one of the things that happens with more doctors is just more care, and more care doesn't necessarily mean better health. And sometimes we have to be removed. If I'm a doctor sitting there, of course I want more patients, but that's not necessarily what's going to make the group of people that I'm taking care of better. What's going to make them better is the individual care that I give to them, the length of time that I spend addressing their issues, And, and instead of putting them on a treadmill and bringing them back over and over and over, doing the same thing and not doing anything right, just doing it for the medical industrial complex. We do need more colleges and more access to colleges so that we can have more of everybody.
Oh, thank you again very much, Dr. Moore. Thank you to Laurie Davis Ford for setting up tonight.
Thank you all for your attention and great questions.